OsteoHealth Company, in collaboration with Dr. Michael McGuire, presents an innovative approach to root coverage grafts using Mucograft collagen matrix. Dr. McGuire is a director of the American Board of Periodontology and is past president of the American Academy of Periodontology. He maintains a full-time private practice limited to periodontics in Houston, Texas, and is a clinical assistant professor of periodontics at both the University of Texas Dental Branch at Houston and the University of Texas Health Science Center at San Antonio. He participates in clinical research and has published many papers in prestigious journals as well as contributed to chapters in textbooks. The presentation that follows provides guidance on how Dr. Michael McGuire addresses challenging clinical situations in his private practice with Mucograft collagen matrix. Dr. McGuire's technique eliminates the need for a remote donor site, as is required with autologous tissue grafts. Mucograft is a three-dimensional collagen matrix which provides a ready-to-use alternative to autologous soft tissue grafts by acting as a scaffold for the regeneration of gingiva or mucosa. Mucograft is a bilayer matrix. The compact layer provides strength and allows the matrix to be easily sutured. It also protects the graft in open healing situations. The spongy layer is designed to add volume and scaffolding for vascularization and soft tissue integration. A recent randomized controlled clinical study verified the effectiveness of Mucograft in treating gingival recession defects, comparing favorably to connective tissue grafts. Here we see a representative case using Mucograft to treat a substantial gingival recession defect. The procedure that follows will address in detail an innovative technique using Mucograft to treat similar recession defects. The patient presents with Miller Class I recession defects of the maxillary right first and second premolar teeth, with limited amounts of keratinized marginal gingiva. Because of the inadequate zones of attached gingiva, the marginal tissues remain inflamed in spite of excellent home care. The surgeon will place a Mucograft collagen matrix to cover the denuded root surfaces and to establish improved zones of functional attached gingiva. In addition to addressing the patient's desire to avoid an additional surgical site to harvest donor tissue, this procedure affords an unlimited supply of graft material, allowing the surgeon to treat multiple recession defects at a single visit. Starting with a back-action chisel, the surgeon begins the root planing process. Next, a Gracie 1112 curette is used to further refine the root planing as well as to more thoroughly debride the root surfaces. The next step in root preparation is to biomodify the exposed root surfaces with citric acid to remove the bacterial smear layer. The citric acid is allowed to stay in place for approximately 2 minutes, after which sterile saline is used to thoroughly rinse the citric acid from the surgical field. Following root preparation, attention is focused on developing a partial thickness mucoperiosteal flap with 2 divergent vertical releasing incisions. Here, using a 15C blade, the surgeon begins in the distal papillary region, avoiding the free gingival margin on the adjacent tooth, but staying as close to the adjacent tooth as possible. The incision moves apically into the vestibular mucosa. An identical partial thickness incision is made on the mesial aspect of the maxillary right first premolar. Next, careful intrasulcular incisions are made, facilitating reflection of a partial thickness mucoperiosteal flap. Using a periosteal elevator, the surgeon begins at each papillary region and elevates the flap over the crest of the bone. Next, the 15C blade is used to create a partial thickness flap to the depth of the vestibule. Gentle handling while reflecting a partial thickness flap is critical to maintaining soft tissue integrity. Tension must be relieved in the vestibule in order to allow passive coronal advancement of the flap. Using the number 15C blade, the surgeon releases the tissues within the vestibule, allowing passive advancement of the flap. Proper sizing and preparation of Mucograft collagen matrix is critical to a successful result. Please refer to the full prescribing information contained in the package insert before using the product. Using a UNC periodontal probe, the surgeon measures both the width and height dimensional requirements necessary for placing the graft material. Next, Mucograft is shaped to cover the exposed root surfaces. Following proper sizing and trimming of Mucograft, the matrix is carried dry to the site and positioned to cover all exposed root surfaces. The surgeon allows the Mucograft to sit passively and become saturated with the patient's blood. Proper immobilization of Mucograft collagen matrix is recommended when treating recession defects. Mucograft is sutured interproximally at each papillary region using the suture material of your choice. Having stabilized the Mucograft three-dimensional collagen matrix, the soft tissue flap is passively coronally advanced to the level of the CEJ or beyond, effectively creating a new gingival margin. Resorbable sutures are carefully placed at each papilla area in order to initially stabilize the flap into its properly advanced position. Each vertical releasing incision is then sutured. Here, at the end of the procedure, hemostasis is complete, and the coronally advanced flap remains passively sutured into position. Note that the free gingival margin is now at the level of the CEJ, completely eliminating the prior gingival recession defects.